It's really a tremendous pleasure to be here today to tell you a story about work that we've been doing for now well over 20 years. To talk really about a very exciting advance in the field, which is a new generation of antidepressant medications that can work very rapidly. In particular, a drug that was just approved by the FDA, which is called Ketamine. No science is done by a single person by themselves anymore. And the discoveries that I'm going to be telling you about are really team efforts. And I particularly want to highlight Dennis Charney, who was my mentor and collaborator. And together we came up with the idea of testing ketamine as an antidepressant. I do want to note that I have some financial conflicts related to the work that I'm going to tell you about. In particular, patents related to the discovery of the antidepressant effects of ketamine were licensed by Janssen Pharmaceuticals, who turned that into a new treatment, Ketamine, that was approved by the FDA. And like everybody else here today, I really want to thank Garen and Sherry for their effort, advocacy, for all the work they do, advancing mental illness. And just to say that we have joined all of you. In 2019, we gave them our Yale Mental Health Research Advocacy Award in San Francisco. We were thrilled to share that event with you. Garen and Sherry, thank you so much. So, antidepressants, where do we get them? All of the types of antidepressant medications that we currently widely prescribe were discovered before 1960. And it has been 60 years since we have had a new way to treat depression using medications. And this year, we have had two new medications. One, the Janssen drug Ketamine, which is highlighted here and which I'll be talking about today. And the second, a Sage drug called brexanolone, which was developed for the treatment of postpartum depression. So this is a new moment for the treatment of depression. What's depression? Ironically, of all the things that I'm going to be talking about today, that's the simplest but yet the hardest to answer. It's a pervasive state of dis-ease that can affect all aspects of a person's life. It is not like having a bad day. It is like being in hell every day. And that's what we're going to try to solve, and that's what the research is all about. We know that depression is very distressing, but for many people, depression is worse than we thought. It's certainly more common. The diagnosis of major depression at any given time affects about 7% of everybody. But depression-related conditions, if you lump them all together, can affect at any given moment a much larger group of people. Depression is more disabling than you think of. It is the single most disabling medical condition that we have. Not cancer, not heart attack, not HIV, depression. And it is more lethal than you probably expect. As we already heard this morning, the toll of depression in terms of suicide is just a terrible burden that families and society bear. And if you have an episode of depression, the chances of your life being shorter by a period of time is also present. And that's partly because depression, for many people, is a disorder that affects your entire body. It can be the canary in the coal mine, a warning sign of impending inflammation in the body, heart disease, diseases that affect other organs in the body as well. The bad news is that antidepressant medications are less effective than we thought. In a study commissioned by One Mind advisory co-chair Steve Hyman, called the STAR-D trial and conducted by some of the people who are here with us today, we found that when people are started on medications, too few of people will get back to their usual level, what we call remission. Only about 1 in 3. That responses are too incremental, that over multiple treatments, still, after a year, a large number of people, maybe as many as a third of people, will not have achieved a remission, or in other words, a full recovery from their depression. The response to most of our medications is too slow. You start a medication, you take it every day, and yet you may not get back to yourself for as much as 2 months if you're one of the lucky people to respond. And the responses, once achieved, as you probably know, are too unstable. So if you're one of the unlucky people to have a medication that doesn't respond to a standard treatment right away, the chances that once you get better that you're going to relapse are about 75% within a year. So if we told people who were starting their antidepressants, even though we know that these drugs help many, many people, if we told them that they had to take a pill every day in order, because there's a 1 out of 3 chance they're going to respond, that it's going to take 2 months, and that they have a 75% chance of relapsing, people might not be so excited about starting the standard antidepressants that we have to treat depression. Now, you might be wondering, why did it take us 60 years to come up with new kinds of treatments for depression? And part of it has to do with the way that scientists think, which is that we tend to dig deeper and deeper and deeper in some of the same mental trenches and to follow the same path. And for depression, that conceptual trench had to do with how most standard antidepressants work, targeting 2 main chemical systems in the brain. One called serotonin, which is targeted by serotonin reuptake inhibiting drugs like Prozac, and the other norepinephrine, targeted by many commonly prescribed antidepressant medications. And research led by my colleague Dennis Charney at Yale provided evidence that these drugs really work by engaging these systems. So that if you deplete the body of serotonin, you can transiently reverse the effects of a drug, serotonin reuptake inhibiting drug like Prozac. If you deplete the body of norepinephrine, you can transiently reverse the antidepressant effects of a drug like bupropion or dizipramine that works on norepinephrine. And if you deplete both of these systems, you can transiently reverse the antidepressant effects of most standard antidepressant treatments. And this is the kind of thinking that really pulled the field to focus on serotonin and norepinephrine as a treatment, as a mechanism of depression. But there is a problem that came out of this research, a conceptual conundrum. And the conundrum is that if you take a healthy person and deplete serotonin, they don't get depressed. If you take a healthy person and you deplete their norepinephrine, they don't get depressed. And if you deplete both serotonin and norepinephrine, they still don't get depressed. So what did this mean? How could you deplete the body of the very chemicals that people thought protected you from depression and not get depression? Dennis Charney and I wrestled with this conundrum over a period of time and thought that maybe the problem lay in our perspective on the biology of depression. In other words, we were focused on the norepinephrine and the serotonin systems, which are cells that live in very primitive parts of the brain and tune the activity of higher brain centers. What if depression didn't live in these primitive parts of the brain? What if depression lived in the higher centers of the brain involved in emotion? The cerebral cortex or the limbic system, which is involved in generating emotion, the cerebral cortex involved in regulating emotion. That change in perspective had a profound implication for thinking about the biology of depression, because the primitive parts of the brain use norepinephrine and serotonin to communicate, but the higher centers of the brain use different chemical messengers, particularly glutamate and GABA. So we wanted to probe glutamate. How could we probe glutamate? It turns out that had been the major focus of my research, which up until then had been mainly focused on the biology of schizophrenia. And I had used a drug, an anesthetic medication, sometimes used to treat pain, called ketamine, which blocks some of the actions of glutamate in the brain. And we thought that we could give a dose of ketamine and block some of the effects of glutamate in the brain, and that would tell us something about the biology of depression. And indeed, it told us a whole lot more than we expected. What it told us was that ketamine does indeed produce some transient effects that wear off within an hour or two. But before we were sending people home at the end of their test days, they began to say, I feel a little lighter. I feel maybe a little better. And then when we checked in on them the next day, some people said, I feel all better. And we said, what? You feel all better within 24 hours from a single dose of a drug that's never been used to treat depression? They said, that's what it is. This was really a profound and shocking in some way observation for us. We could not have expected, even based on some of the basic science clues that we were following, we could not have expected such a profound and rapid clinical response so quickly after getting a single dose of ketamine. So what's it really like to get treated with ketamine? Let me have someone else tell you who's gone through it themselves.
I've been in treatment pretty consistently since I was in middle school. I had a combination of different styles of therapy as well as different medications, and my functioning was pretty high, but I tended to still really struggle with these feelings of just profound aloneness and despair. And about 3 years ago, I kind of slipped into what I would consider a very severe depression. I'm receiving intravenous ketamine, and the day after I received my first treatment, I felt like myself. But what was strange, it was like immediate. The next day I woke up and I felt I could internalize good things about myself. I could feel positive feelings. I could feel feelings in general. The gratitude I have for this treatment. And so thankful I live in an area where there's such innovation happening. I didn't even know this was possible.
I apologize for a little bit of the commercial that came up at the end of that, but you get the feeling of what ketamine response can be like. It can be like a profound return to oneself, not in the induction of a state of euphoria or altered consciousness, but a return to oneself. And ketamine does not produce elevations in mood, persisting elevations in mood in people who do not have psychiatric disorders. It is not a life-enhancing treatment in that way for healthy people, but it does alleviate the symptoms of depression. And the remarkable story about what it does to the brain is part about what we're going to talk about in just a little bit. So one of the interesting things about ketamine is that it seems to work for the most treatment-resistant symptoms in the most treatment-resistant patients. And what I mean by that is some of the most concerning symptoms in severely ill patients, like suicidal ideation, seem to recover. And even if you study the most acutely suicidal patients, you can still show, as two new studies conducted with S-ketamine, a variation on ketamine, the Janssen drug, they just reported exciting data in very severe suicidal populations of its beneficial effects on depression. Now, I mentioned that the three problems are you don't get better, it takes too long, and once you get better, you relapse. And as limitations of many of our standard treatments. But ketamine appears to have a very strong protective effect when the doses are repeated on relapse to depression. And this large study showed that over a year of treatment, among people who responded to a combination of an antidepressant plus ketamine, that staying on antidepressant plus ketamine was almost twice as protective against relapse over a year as people who just stayed on a regular antidepressant treatment. So this is an important observation. It's not just getting people better, but it's helping to protect against relapse, which I think in the long run is really an important part of any kind of treatment that we develop. Another unique, distinctive feature about ketamine is that it seems to, in some early studies, have some effectiveness for post-traumatic stress symptoms, which often don't respond very well to the standard antidepressant medications. And this is something that we and other groups are studying now in large-scale, more definitive kinds of studies. So what I've presented so far suggests the possibility that ketamine and S-ketamine, the Spravato, the intranasal form of ketamine, may be a new hope for many people who haven't been able to respond, get the kind of response that they want or need from the standard kind of antidepressant treatments that we have. And it's not only good at getting people better, but also helping to prevent the return of depression symptoms. Now, Time magazine, when they did their article about ketamine, called it the antidepressant. And I kind of like that name because ketamine is a very different kind of drug. It's a drug you start maybe taking twice a week for a while, then once a week, then maybe once every other week, then maybe once a month. And so about 30-40% of patients treated with S-ketamine are really only taking the drug once a month, but maintaining their benefit over a long period of time. How does a drug that is so short-acting produce effects that are so long-acting? And that's been part of the surprise and interesting story about the biology of the antidepressant effects of ketamine. In order to tell you this story, and this is a figure from my colleague Jeff Lichtman, you need to understand something about how nerve cells communicate with each other. So we're drilling in, it's a slice of the brain, and we're drilling in on the glutamate cells in the brain, sometimes called pyramidal neurons. And we're getting up close, and we're going to zoom in on this part of the nerve cell. All right, good. So you see that there are this is the input to a nerve cell called a dendrite. And on the dendrite are these blebs that are sometimes called dendritic spines. These are the sockets that are made when one nerve cell communicates to another. And it is there that on these dendritic spines that glutamate receptors are often located and involved in communication. But one of the interesting things, and this is the work of now Ron Duman and George Agajanian, and you see here is a different way of looking at a dendrite and the spines, the sockets, the places where the synaptic connections between nerve cells are made. Stress, things like depression, deplete the inputs of those dendritic spines, making the communication in the brain less effective and less efficient. And a single dose of ketamine in animals causes these synaptic connections, these dendritic spines, to rapidly grow back and make synaptic connections. So at this point, you're probably saying, great, but what does that have to do with depression? Is there a way to try to make a case that these same processes are happening in people with depression and that these synaptic connections are growing in people's brains? So again, here is a synapse, and it's releasing various chemicals onto receptors. And we have developed at Yale, Richard Carson has developed a PET radio tracer that tags these little vesicles and gives us a way to quantify the density of these synaptic connections in the brain. And what we found in a study led by Irina Esterlis and Sophie Holmes, that in patients with severe depression and PTSD, we can for the first time show a reduction in the synaptic connections in parts of the brain involved in the regulation of mood, like the prefrontal cortex and the hippocampus and amygdala. Not only that, but the reductions in synaptic connections in the brain seem like they're related to inefficient communication in the brain, which we can measure using a technique called functional magnetic resonance imaging, or fMRI. What's important about that is that when we see these reductions in efficient communication in the brain on fMRI scans, a study led by Chadi Abdullah in collaboration with James Morrow and people at Mount Sinai, it is that 24 hours after a single dose of ketamine, that inefficiency in brain communication is fixed, goes away. So there's a hint that the story that comes out of the studies in rodents from Dr. Duman and Agajanian and others, Connor Liston here, who's here in the audience, that story is really relevant to the alleviation of suffering in people with depression. So, in conclusion, what I've tried to tell you is a story about how science can advance, how it can change the way that we think about the treatment of problems like depression, and how all of that is really rooted in advances in brain science that make all the rest possible. So I think I'm going to stop there, and I think there's some time to take questions. So thank you very much. It was a wonderful pleasure to speak to all of you today.